Yeah, good afternoon, and thanks Raju and team for giving me the opportunity to come over here and present my case. It's a very simple case, but it's a rare case. That's why I am presenting in. 28-year male presented with persistent deep pain on posterior aspect of right shoulder, with history of fall from own vehicle in a road traffic accident 1.5 year back, and sustained shoulder injury which subsided with medications and rest. But after some days, he felt pain in the shoulder on the posterior aspect again, which was worsening whenever he was doing push-ups and bench press, because he was a regular gym goer also. And also he had pain during some overhead activities like playing badminton, and at times he was feeling clicking in the shoulder while doing range of movement and instability on and off. He was taking on and off analgesic during this entire duration, but ultimately discontinued gym 9 months back because of his persistent discomfort while going to gym. And after that, he consulted an ortho doctor somewhere else, and he put him on this physio regime. And then he was on conservative treatment. He was feeling little better, but for last 4 months he was feeling discomfort even in the right shoulder, even while doing the desk job for a longer time. He consulted few doctors again, but continued to have same posterior shoulder pain, and he presented to us. So on examination, we found to have posterior joint line tenderness. Range of movement was full. The posterior apprehension test was positive. The provocative tests were positive. Jerk test was positive. Kim test was positive. Posterior load and shift test was positive. Sulcus sign was negative. The Beaten score is 3/5, normal. The strength testing and neurovascular examination were also normal. And there was no scapular dyskinesia per se. The X-ray, there was no major abnormalities except mild retroversion of the humeral head. And the CT scan, there was no bony changes like fracture, hypoplasia, retroversion or reverse heel sacks in the CT scan. Unfortunately, I don't have these pictures because the patient lost it and didn't bring it in the follow-up visits. But we had the MRI pictures, and these are the MRI pictures of his shoulder when we did it. And you can find the lesions in the MRI picture as well. So it's over to the house for the diagnosis and what they think the management should be. Whether they go for the conservative management further or do something operatively.
So, Dr. Maheshwari,
So you can
inputs.
see in all these pictures the lesion over here.
So what would you have done if he had come to you? Because you also presented a similar case with vague symptoms, and these are not common everyday practice. What is your thought process in this situation?
How many months or what is the time duration of symptoms, sir?
1.5 years.
Okay.
Here, such symptoms in young people, particularly sports people, bench press, push-ups, is very highly suggestive of a posterior instability.
Sir.
Unfortunately, no signs and symptoms. Even MRI is very vague most of the time. So after having tried everything, I have a low threshold for doing diagnostic arthroscopy and then proceed.
So do you ever do a MR arthrography for these instead of doing if you're suspecting a posterior lateral tear? And
theoretically yes, but practically no, because I don't find somebody doing it very well, and every time my radiologist tell me 3T is good enough. So
the diagnostic scopy you would do to see for posterior instability, or?
I will see what is happening. There is something happening in this young man.
Okay.
Most likely my clinical diagnosis is posterior instability.
Yes.
If I find that, stabilize it. Otherwise I look around the joint, see everything properly. If I don't find something, I tell him, thank you very much. You have nothing wrong, get lost.
See, Dr. Panigrahi, I see a couple of issues in this MRI. I mean,
Yes.
of course the posterior labral tear is there, which is, so patient is presenting with posterior labral tear, but posterior labral tear should not be painful in the night. You said pain in the night. No instability patient is painful in the night until unless accompanied, and that raises a warning in my head. I don't like this end-fast view of the glenoid where it is showing more excessive edema, not coming onto the face of the glenoid. I don't like it. Third issue is, I don't like the convexity of the glenoid. The glenoid is convex. You said CT didn't have any retroversion. Retroversion is not the concern, it is the dysplastic glenoid. This MRI is not, this is not a normal glenoid. There is no concavity in the glenoid, this is convexity in the glenoid on the axial cuts. These are my issues. Of course, labral tear can be repaired, and if that improves the patient, fine, but then this is the issue, I think, which you could counter-check with your CT scan.
I think what I see here is the head is posteriorly subluxated. There is a posterior glenoid erosion. So I'm sure there is a centering issue here, and probably posteriorly it is lax, and if you tighten that, you should be able to center and make it pain-free.
So, in the MRI with these symptoms, the patient has a posterior labral tear. I think
Also-
most of you will go and do and repair it.
Shashank wants to ask something.
Shashank, please go on.
So, as Raman pointed out, it seems more like a convexity of the glenoid rather than erosion of the posterior glenoid. Do you think just by repairing this posterior labrum, we will be able to center the humeral head because of this convexity?
Also,
Shashank, the patient is, what is the age of the patient, Dr. Panigrahi?
28 years.
So he's living with this glenoid, doing all the activities for 28 years now, and it's become symptomatic for the last 1.5 years. Correcting the convexity of the glenoid might be a very, very dicey procedure. It is just not the inclination, it is the convexity. Any kind of bony procedure will not work. So we don't have any option but to go ahead with an arthroscopic repair and see if the patient improves. But counseling the patient that this is a problem congenitally and this problem may recur, that is what I would do. I would definitely try to rule out the osteonecrosis of the glenoid in this patient. Dinsha has published in badminton patients, and this unfast view points a finger at that. So I would try to rule that out as well.
Dr. Ram?
Exactly. That's the thing I was coming to. That white signal in the posterior glenoid it just reveals some eccentric loading on the posterior glenoid. By repairing that, we might make that shoulder more painful.
Yeah.
Dr. Raman, you said these instability patients would not be painful in the night. But logically thinking, a posterior labral tear with this cystic sort of formation at the edge of posterior glenoid while lying down.
Ankit, too small a cyst. I mean, paralabral cyst with posterior labral tear is a different ball game altogether. But if we are just talking about the labral pathology, no Bankart patient is ever painful in the night.
No, I said posterior.
Even posterior, they're not painful in the night.
Erosion, it's an osteo component which is making it
They are not painful in the night. Instability patients are usually not painful.
So, on a lighter note, most 28-year-olds are very active in the night, so that can also be the reason for the pain.
I'll just put one more fact out here. I was with Professor Yeon-sik Yoo for some time in South Korea. He has a very special interest in posterior shoulder instability. I am not sure if he's come out with his publication or not. When I was there, we screened about 100 patients, just about 100 patients from his archives of radiology, records. And as you mentioned, sir, most of the posterior shoulder, atraumatic posterior shoulder instability patients had this sort of glenoid morphology. Most of them. So I don't remember the exact number, but about 70-75% had slight convexity of the glenoid.
Or it is habitual.
So this is
you are short both ways in posterior instability.
This is really a finding. Glenoid morphology is different with atraumatic posterior shoulder instability patients.
Yeah, the point to note is the patient was absolutely all right till 28 years. He was doing everything till he had the trauma. After the trauma, repetitive microtrauma, which caused this kind of symptoms. Before that, he was absolutely fine, no problem, nothing. So I don't think the glenoid is an issue. So the posterior inferior labral tear, maybe a cartilage involvement.
Ranjit,
so we did.
Pratap has a point to make.
Yeah, I do completely agree. At 28 years, he probably started doing more and more of aggressive, gym, something like that, and torn the posterior labrum. And that was the starting point rather than osteonecrosis or anything like that.
Right. So we did the diagnostic arthroscopy. So the interlabral labrum was good. Biceps sling was intact. The middle glenohumeral ligament, subscap, interlabrum, the capsular reflection, the cuff, everything normal except on the posterior part. So like in instability case, we did both this mid-glenoid portal as well as this enterosuper portal, like we make for the enter instability, and through the mid-glenoid portal with a probe, we just saw the interlabrum was okay, no problem, but there is a tear in the posterior labrum from 630 to 930 almost, and the underlying glenoid bone is not good with a lot of fibrous tissue over a lesion. So now what will you do? Okay, so what will you do for this chondral element? What will you do for this labral element? What will you do for the capsular element? There are three elements in the posterior instability cases. Because of the repetitive microtrauma also, the capsule is a little bit lax on the posterior side. So for these three elements, what are you planning to?
So if you ask me, I'll proceed with the capsulolabral repair. I will not be too tight. I will bring the posterior labrum flush to the glenoid cartilage. That's it, because that's how the normal posterior labrum is. And I will ask the patient to be very, very careful in the gym, not to do heavy weights, and if at all he has to do, he has to use a wide grip instead of a narrow grip for his bench press, and never on an incline. You can't do anything else about the cartilage.
Pratap sir?
Yeah, I think I will release the capsule and labrum and the capsule and take a bite together, the capsule labrum bite together, so that there will be a decent type of.
Pratap, what is your preferred viewing portal? What is your preferred instrumentation portal for this?
Okay, I will use one of the switcher passing devices. Otherwise, it's very, very difficult to take the bite from there.
So which portal are you viewing from? Which portal are you working from?
Okay, my viewing portal is going to be the anterior portal, so that I can have a good look.
And your working portal is the posterior portal?
Posterior, yeah.
Okay, okay. Sir, what kind of anchors you are going to put and where you are going to put that? Is it knotted anchor or knotless anchor?
No, I always use knotted anchor.
Knotted anchor.
Yeah,
so where you will put now?
Yeah, I think if you look at the diagnostic arthroscopy showed from 6 o'clock to probably up to 6, 7, 8 o'clock position, isn't it? That is what you showed. So one probably I will put in right on 6:30, and then second one probably 7:30, and 8 o'clock.
Will you put these anchors on the margin of the glenoid or margin of the lesion, sir?
Margin of the glenoid.
Margin of the
glenoid. I don't want it too tightened there.
Let's get Shashank as well. Shashank, if you're hearing, can you tell us what